19, most of the deaths initially, at least, we were seeing more of the elderly people, more people with other medical complications like diabetes or heart disease or kidney disease. Those were the people who were getting into trouble. Of course, that is changing thanks to the vaccinations that we have given for the elderly and the people with comorbidities. And the other difference is that in influenza, people were dying because of a secondary bacterial infection in the lungs. Whereas in COVID, it is not only the COVID virus that is affecting, it is the overactive immune response in the body. It's what our body is doing to ourselves that's causing the problem. So these are the major differences, at least compared to the biggest pandemic we've had in the recent history to what we are having currently. So over to you, Vijay Anand. You're muted. Vijay Anand, you're muted.
Oh, yeah. Now you're able to. All right. So, are you able to hear me or still?
Sir, actually you joined in from two devices. So that other device is creating an echo.
Right. So that's I did because this was not working. So anyway, is it clear now?
Yes, it's perfectly fine now.
Right. Suneetha, we had the H1N1 with influenza virus in the past and SARS COVID virus 1. How different is this COVID-2 virus?
Those were the other pandemics that we've had. We had H1N1, we had the SARS-CoV, we had Zika, we had the MERS, and so on. So how is, say, for example, if you talk about the MERS or the SARS-CoV-1, there you're, or even compared to the Zika, there the mortality was very high, which means if you get the disease, you're more likely to die of the disease. Whereas in COVID, you're most of the time going to have a milder disease. It doesn't kill you. Though you are seeing a lot of people dying of COVID today, that is because the number of people having the disease is huge. So it is still a proportion of the people that are having the infection. And the number of people who are falling sick and getting into the hospital just reflects how much more the disease is there in the community. So the mortality is still less as far as COVID-19 is concerned, as compared to, say, SARS-CoV-1 or Zika. And because of that very reason, the ability of that to spread to multiple people is also less, because you're more likely to die of disease and you're not spreading. Whereas in COVID-19, you're having a lot of pre-symptomatic phase or asymptomatic phase, because of which you're likely to spread the disease more, and so more people are developing the disease. So yes, it is good that it is having a lower mortality, but it's also disadvantageous in one way because you're likely to spread this more.
Right. So now modes of spread, initially it was thought to through contact, and now we really don't know with the second wave. People are saying it's airborne, and how to protect ourselves in this regard.
So initially, anytime when you have a new pandemic, there's a lot of research that goes on to try to figure out how the disease is spread. So initially, the COVID-19 virus is a SARS virus or the coronavirus, and coronaviruses typically have droplet spread, which is why we thought it's more of a droplet precautions. But what does droplet spread mean? What does airborne spread? First of all, we need to understand these concepts for us to understand what it means to us when people rattle out these words. Droplet spread is where your virus is in the droplets, and the droplets, because they're heavy, because they're in the saliva or other body fluids, don't tend to travel too far from you. They're typically heavy, and so they fall within a couple feet or two in front of you. They don't travel far away. Whereas airborne is you have droplet nuclei or smaller viral particles that tend to be sustained, stay in the air for a period of time. So that's the two major differences. That's a major difference between droplet and airborne spread. So when you have airborne, this viral particles can be sustained in the air for a long period of time. Now, these are not completely two independent entities. It's a false dichotomy. You can have kind of a uh, 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 path between droplet and airborne, and somewhere in between is probably what we are dealing with. Why do we say that there are droplet? It's not a droplet and it is more likely to airborne. We have seen a lot of super spreader events. I'm sure you know about several of your friends and colleagues who had one of these exposure in one of these. Super spreader events mean you are in a there is some kind of an activity where a lot of people are together, and invariably almost everybody in that room or that activity develop an infection. So typically if it's a droplet spread, you can't have too much of super spreader events. So that's one reason why we are thinking it may be an airborne spread. And the other thing is, for example, there was one particular case in Australia, I believe, where there were people in two different hotels who one where in one hotel there was one person who's positive, but there's no other contact except for this person who got who led to the infection to another person in another hotel. So that's the reason why we're talking about this airborne spread. So anyways, it's a these things keep changing, but what we have to remember, the most important thing is how do we protect ourselves? Masks always required, and if you having a good quality air in the place that you're staying in, very helpful. And if you're staying in a room or wherever you are, having room with ventilation is very, very useful, because any infection spreads based on the number of viral particles in per unit area. So if you have a room with ventilation, you're diluting the air with the amount of viral particles, and thereby your likelihood of developing an infection is less. The other thing that you can do is, if you're meeting people, if you're having any events, do it as an outdoor event. Don't do it as a closed door event. That improves your air circulation and thereby decreases the probability that you will develop infection.
So by and large, this is the route of entry is through the nose or through the mouth. Is that right?
That's pretty much it. We initially thought there can be a contact spread, but that seems to be less and less likely based on more information that's coming out.
Right. So by skin contact, by hands touching somebody is very less likely. But most of the time, if you put masks regularly, then you may get away without getting infected. If that is right.
That is right, but you still want to use a namaste instead of a handshake.
All right. So for the doctors, you would suggest them to wear gloves all the time in that case?
No, not for doctors or for anybody else. Wearing gloves all the time is not a good idea, because one, it's not, we just talked about that it's probably not based on contact spread. And even if it is contact, just think about it. If you wear a gloves and you're going around the city or wherever you're going, you have a false sense of notion when you're wearing the gloves that you're protecting yourself by wearing the gloves. And then you tend to touch a lot of surfaces, and because you're wearing the gloves, your sense of perception to the hand is less. Normally your skin sensation is telling you that, okay, I've touched something here that's probably dangerous, go wash your hand. That kind of sense of perception is gone. And then you touch something and then you take that hand into your mouth, onto your face, or touch all kinds of things around you. Your sense of you lose your senses, and that will put you actually at a more high risk behavior, because you have a false sense of security that you're wearing gloves. And it is generally not advisable to wear gloves when you're to protect yourself. It's better to use hand hygiene, that is washing your hands frequently, than to use gloves.
Great. So most often, 9 out of 10, 99% of the times when you're out of the house, we preferably wear masks. And what is the difference between a cloth mask and a N95 mask? Which is a commonest question that people would ask. And most of the homemade masks have been in practice rather than N95 masks, what we see in and out.
N95 mask is commercially available. Basically, it filters out 95% of the viral particles that are circulating, and it will filter out your COVID-19 virus as well. And this is typically used particularly in the hospital settings, where healthcare workers are constantly in touch with the patients who are having COVID. But otherwise, general recommendation is to wear triple layer mask, and now they are talking about double masking, but most important is as long as you are wearing the mask and the opposite person is wearing a mask, both people are wearing the mask, your probability to spread the infection is less. So it is very, very important that both people wear a mask, because if the person who is having an infection is also wearing a mask, where is the viral particles that is being released? It's not released into the air, it's only going into their mask. So you don't need to do anything more than a regular triple layer mask. Even a cloth mask is good enough as long as it's thick enough and has multiple layers on it. But
At least 2 layers,
both should wear
per
two
cotton.
layers, but both should wear a mask. It's not one
Yeah.
person wearing a mask.
So it's like smoking, and when you are not smoking, don't allow others to smoke. So you make sure that you wear a mask, and make sure that others who are coming to meet you, we should make sure that they are also wearing a mask. So now coming to the tests, there are different tests that the people are doing commercially and diagnostic centers. Which are that you would suggest? Which one is that you would suggest?
So there are different kinds of tests. If you're talking about tests, there are broadly classified. There are tests for diagnosis and tests for seeing if you have antibodies. Protection.
Yeah.
So if let's talk about diagnostic tests. For diagnostic tests, you have primarily the rapid antigen test or the molecular diagnostic test, which includes the Rtpcr or TrueNat, GeneXpert, and a bunch of other small things that are not as common. The rapid antigen test is designed on the principle that your body develops antigen to the infecting pathogen, and you're looking for the antigen. The advantage with the rapid antigen test is it's very fast turnaround. You collect all of these tests are based on a nasopharyngeal swab. So you take the swab, put it into the back of your nose, and get a good sample. And if the person has done a good job, you will feel pain. If you don't feel pain and you're thinking that the person did a good job, then it's actually wrong. If you have to feel pain if they've done the test properly. Okay. So if properly collected nasopharyngeal swab is used to do either of these two tests. Rapid antigen test, the advantages is it's a very fast turnaround. You get the answer in about 15 minutes. But the disadvantage with rapid antigen test is its sensitivity. When I'm talking about sensitivity, it means if I have the disease, what is the probability the test will be positive? It's about 50%. And that's not necessarily the best, but then because it is advantage rapid and it is cheap, we use it quite a bit. Whereas the Rtpcr or the TrueNat is a molecular diagnostic test, which means we extract the DNA or the RNA. In this case, RNA. We extract the RNA out of the sample and then look to see if it matches to the RNA that you're looking for. So you're looking for if you remember your school time, you have the DNA double helix model. So you kind of take a part of the DNA of the COVID virus and see if it matches to the sample. These advantages of looking for the DNA in this case is it has a much better sensitivity, which is like 70%, which means if you have the disease, 70% of the time the test will be positive.
But you have false positivity in Rtpcr, which is very unlikely. But still, we are seeing some patients getting Rtpcr positive and they still remain negative.
So it is the only time when you can get an Rtpcr positive is if the sample is not handled properly, which is otherwise there is no reason why you should have a false positive report. The thing is, if you have mild symptoms, or if you don't have symptoms and you're a contact, you may be exposed to the virus and you may not have developed the disease. That's called an infection and not a disease. These are difficult to comprehend, but you can be infected with the virus and not develop the disease in your body. Okay, so you may have done the test for whatever reason, because maybe you're in contact with somebody who is positive, and the test comes positive, and because you believe that you don't have the disease, you go test it again next time, it may come negative. It can come negative for multiple reasons. Like I told you, you can have the virus, but it may not pick it up for various reasons. The sensitivity is only 70%. But also, it may be just that your virus is not there for long enough duration for it to be positive all the time. Your virus can be short-lived in your body, or it can stay in the body for a long period of time, sometimes as long as several months in some people.
So
So
that gives you a second question. What is the right time that we should go for this test? People are getting panicked. They just go repeatedly to the labs and getting tests done. So I keep telling them there's absolutely no need to get the test done. So what do you think, Suneetha?
So today, with the pandemic that we are having, if you have symptoms suggestive of COVID, which is fever, cough, sore throat, loss of smell, loss of taste, any of these major symptoms, you have to get yourself tested. You don't keep testing yourself every time you're getting out of the house, or because you're worried you're going to spread it to your family members. You can't keep testing weekly. That's not a good idea. But if you have symptoms, you have to get tested. And if you have been in contact with somebody who is COVID positive, a contact is should be a significant contact. Just because you know somebody in your company has COVID, but you did not have a direct one-on-one contact with that person, then you don't really need to test. You should have a one-on-one contact with that person without your own protection. Like if both of you were wearing a mask and you had chatted with each other for a couple of minutes and then moved on, then the risk is actually less. But if you're, say, in a conference room together, about 5 or 10 people or whatever the number be, and all of you all were sitting and discussing and had coffees and teas at the same time, then that's a significant contact that you have to be tested to see if you develop the disease at a later point. And if you're testing because you're a contact, you don't have to test it immediately. You can wait for a 5 to 7 days if you're asymptomatic and then get tested later. There is no reason to rush and get tested, because your test can be negative in the beginning and can come back positive later.
This is very, very important to note, Mr. Suresh. So when people are getting panicked and all the 10 people in the meeting go and get tested, then that will invariably negative at that point of time. So after 5 days or 7 days, when you get temperature, when you get symptoms, then it is worth testing. Prophylactically or preventively, you're not going to get benefited by doing it testing. All right. So now, once somebody gets infected, Suneetha, we do. So I've seen so many people going out and testing their antibodies level. I don't know whether it is really required and how essential is that.
See, antibodies develop when you have an infection in your when any pathogen enters into your body. Then you develop protective antibodies to that pathogen at some point in time. There are different kinds of antibodies that the body can develop. It makes you feel good that you have antibodies when you do the test and you have antibodies. Sometimes even after a severe disease, you may not mount an antibody response and your antibodies can be negative. However, what you have to remember is antibodies, even if you have antibodies, does not mean that you're protected.
Exactly.
Okay, so you can have the disease, you can have vaccine, and after both of those, you can still get a COVID infection. Usually, if you have been vaccinated, the next time around you get the infection, you're likely to have a mild disease. You won't have a severe disease, but you can develop the disease. So do not get into this concept of that, okay, I'm going to get tested for antibodies. It is probable that that idea also is leading to this, contributing to the second wave, not completely, but contributing. For example, if say a few of us have had COVID and we think that, okay, I've checked antibodies and say that I have antibodies, and then a few more take the COVID vaccine and then check themselves and see that they have a vaccine, and then they think that, okay, they're immune to the vaccine, immune because they took the vaccine, and then they go around thinking that, okay, I'm invincible now, I'm fine, I will not develop COVID, and then we'll put ourselves at a high risk behavior. Now, this high-risk behavior will make you develop infection. Now, when you develop infection, because it is a mild infection for you, you will not even realize that, and you may be spreading the disease more. Okay, so it is very, very important that you take precautions, even if you've taken the vaccine, even if you've had the disease, and what are you going to do with the antibody report other than getting a false sense of security? Just don't bother with it. And if you don't know whether you have antibodies or not, at least you'll be cautious.
This is very, very important, Suneetha. It's good that you brought it out very clearly. So having an antibodies does not make you immune at all. You're not invincible. You need to continue the guidelines as a COVID precautionary guidelines, wear the mask all the time. Now, this second wave has hit us very, very hard, Suneetha. What do you think that we are going to, how long this second wave is expected, and nobody can be sure what's going to happen, but how long this second wave is going to? Number two, do we expect a third wave too?
Okay. So based on our experience, say for example, in the first wave, generally based on previous experiences with previous pandemics, as well as other mathematical modeling, we knew from the time the first wave hit us that if you do develop second wave, it is probably going to be more severe than the first wave, which was seen in multiple other countries that have had second and third waves. For example, Europe and US, where they've had second and third waves, they know we know that second waves typically are more severe than the first wave. And why? What probably happened is that when certain percentage of the population in the community develop some sort of an immunity, the numbers decrease and then kind of have a lull. But then after a certain point, a new set of people start developing the disease because they have not yet developed the immunity. In this case, what we are seeing is more younger people developing the disease. One, because most of the older people may have already had the disease in the first wave, or two, most of the older people have been vaccinated and so they are being protected. Now the younger people who are now, because the older people are vaccinated, are taking life easy, put themselves at high risk behavior, and all of these people are developing the infection. So that's probably the reason why more younger people are developing infections in the second wave. If you look at what is happening in Mumbai, there or in Maharashtra, to be more precise, their infection second wave probably started early March, and now we are seeing it trending down. Mumbai, Pune, the numbers are going down right now. So if you look at that and try to extrapolate that to, say, for example, Telangana, our peak is not yet happened. We started much later, and it is probable that our peak will be sometime like, say, maybe mid-May. And after that, things may go down. But remember, the peaks and the decrease in the number of cases will be different for each place. For example, Hyderabad may be different from Warangal, may be different from Adilabad. It will probably different in each place depending on when the number of cases increase in that particular location. So, yeah.
So now, as you rightly said earlier, most of the senior citizens used to get affected. Younger people, very few people were affected. Now you see with the second wave, more and more young people are getting affected. Why is this change?
So like we just talked about, multiple different reasons. One, older people have been vaccinated. In fact, what I've noticed currently in my hospital is I have people who are older than 90 years, but they are actually doing well. Whereas the younger people are not doing as well. And if you actually see this, we are in the process of evaluating this. If you look at the CT scans of all the people that have COVID, and we probably looked at about 100 or 150 in the last week or two, and you compare the CT severity with the information of whether you have taken the vaccine or not. People who have taken both vaccines do not have severe disease. They may have disease, but it's always been mild. Okay, so older people and high-risk people have been vaccinated, and so their disease is mild. And when you're having huge numbers of infections running into officially lakhs, but probably much more than what we are hearing. So even if you're talking about a small percentage of these people developing a severity in the illness, that number will be large. The raw numbers will be large because the bottom line is huge. So the older people are being safe because they have some sort of a protection. The younger people are not being protected, and so they are seeing a severe disease. I don't think it is necessarily more people, more percentage of people are falling sick, but its overall numbers are more.
But so happy to know that the virus does spare kids and infants. Why is this?
Well, that's $1 million question. We still have to find answers for that. But kids are not falling as sick, but they can be source of transmission of the disease.
Right, right. But what I understood is that the T cell immunity in these kids are much better than the adults. So the T cell
It's
immunity
possible.
helps them to protect them from virus infection. So that's about, and then the vaccine, the commonest question people, I'm sure they ask you as well, which is better, Covishield or Covaxin?
So, uh, if you have a vaccine, go ahead and take it, whichever it is. See, the answer to this question changes almost on a weekly or a bi-weekly basis, or I mean, once in 2 weeks or 3 weeks, based on the information that evolves. Because these are vaccines that are still under research, or a lot of the studies have been done, but they're still, that's only a short follow-up. Phase 4, that is, monitoring is being continued even after the vaccinations are being given. So we are learning a lot more about the vaccines as we are using them. So what answer will be today may be different from what it is tomorrow and what it is a month from now. So is there a huge difference in terms of one vaccine versus the other? Probably not. Are there some side effects with certain vaccines? Probably yes. But if you look at the risk versus benefit ratio, if you develop the disease and have complication from the disease versus complication from the vaccine, it is so minuscule. The complication from the vaccine is so minuscule that you should take the vaccine, whichever it may be. If it's Covishield that's available with at that point in time, take the Covishield. If it is Covaxin that is available, take the Covaxin, because these are things that are information is evolving and more information is coming out.
Now, why it is for 6 weeks interval for Covishield and 4 weeks for Covaxin?
The studies that were done with Covaxin were done at 4 weeks. So that's the reason why we have it as 4 weeks. Whereas with Covishield, we have data not necessarily from the research study, but from usage study, where UK had decided that because they want to do more of a general, okay, what did UK decide? Covaxin, 1 dose gives you protection for there's a 55% chance of getting a protection from the first dose.
First dose.
If I give second dose, my protection can go anywhere between 70 and 90%. So if I give more people the first dose, my herd immunity in the community is going to be more. With that strategy, UK decided that it will delay the second dose so that more people can get the first dose. And after that, it was found that even if you, as they were following these people, delaying the second dose actually helped get a longer duration of immunity. So then it was decided that why try to give it at 4 weeks, because now we are getting the data, just delay to more. UK actually says 8 to 12 weeks, or even WHO says 8 to 12 weeks. We are in India, we are saying 6 weeks. Is there a research study for this? No, but there has been experience, and that's the reason why that recommendation has come out.
Perfect. In the present scenario, because of a shortage of the vaccine, so don't get panicked. You can pretty well take after 6 to 8 weeks or even 12 weeks if you are taking Covishield.
Also remember, we are going to have to deal with this problem for a longer duration.
Yeah.
So having a longer duration of protection is equally important. So if I'm going to delay this vaccine a little bit and have a longer duration of protection, why not? Because now we're talking even about a possibility of a third wave coming up. So you need a longer protection.
So can we take first dose of one vaccine and second dose of another vaccine?
That is not recommended.
Yes.
That is not recommended.
That should come from you. So that's a common question again people would ask. And the pregnant women and feeding mothers, can they get vaccinated?
Feeding mothers can get vaccinated. Today's news from CDC, I believe, has told that pregnant women can also get the vaccine.
Now you're expecting Sputnik from Russia. How different is this vaccine?
See, Sputnik vaccine is also using this the human
MicroRNA.
adenoviral vector similar to the Covishield, which uses the adenoviral vector. So it's not too much different to that. The research that came out of it says that efficacy is 91%, but I think that's subject to, I mean, a lot of this information keeps changing over a period of time. To me, again, Sputnik, Covishield, Covaxin, just take which you have, whatever you get.
Now, most of them are, some of the patients, some of the people are asymptomatic and after being infected, so they don't get tested. And so in that scenario, what happens if they get vaccinated?
See, even if you have if you're in an asymptomatic phase and you take the vaccine, one, you're probably going to just develop the infection like any other person. It is unlikely that it will be a more severe disease or anything, though that is one fear that a lot of people keep having and a lot of questions are being asked on that. It is unlikely that the vaccine is going to change the course of the disease that you're going to get.
So it's safe. In other words, it's safe to go ahead and get
It is safe.
vaccinated.
You don't need to get yourself tested for COVID just because you want to go get a vaccine.
Excellent. So also people who are COVID infected, can they be given COVID vaccine? We almost answered that question, but I just wanted to make sure that the people who are infected, they think that they've got plenty of antibodies, they don't require vaccine.
So
But,
if you
please.
have an infection, COVID infection, and develop immunity, it's more likely to be a short-lived immunity, whereas the vaccine is more likely to give a longer duration of immunity. So even if you've taken the if you had COVID, please take the COVID vaccine, and and if you have had COVID, delay the vaccine by at least a month after the disease. If you have received plasma or any immunosuppressive drugs for COVID, including very high dose steroids, delay the vaccine for a good 3 months after the immunosuppressive drugs that have been given. Because vaccines don't work very well in the presence of immunosuppression.
Great. The treatment protocol has been frequently changing. So antiviral drugs and number of new antiviral drugs have been floated in the market. So WHO has by itself has changed so many recommendations so frequently. So what is your take on it?
Actually, that's the way we interpreted the WHO recommendation is what I would say. Even in the beginning, from the beginning, WHO has been saying that remdesivir, which has been talked about a lot, is not going to help you significantly. And if you're using it, use it in a research study, use it in only certain groups of people where it may help. Don't use it too early because it doesn't really help. And it has always used that caution statement all the time. But we, because of our own anxiety, want to try out some therapy because just sitting and watching is difficult. Have been trying all kinds of options. But in terms of remdesivir, I think WHO has actually maintained a uniform stance throughout. And most of the drugs, remember, normally if you're talking about a new drug that comes into market, there is a good 10 to 20-year research that goes in. Here, we hardly have any research that's going in, and every article that comes out is not peer-reviewed by the scientific community, but is peer-reviewed by the entire world, which makes it very difficult to have a non-biased opinion about articles.
But in general, Suneetha, sorry to interrupt, if it is not that important to give it to a patient who has COVID positive, we as a doctor, we should be able to convince the patients and patient attenders that it is as a matter of fact we are giving, but it is not compulsory medicine, because people are just going berserk outside into the market and spending lakhs of rupees in the black to buy these medicines, especially remdesivir and tocilizumab. So it's not necessary that these patients require. It is not a definitely not a life-saving drug. If it is available, you use it. If it is not, it's okay. So that message has to go on to the public.
Absolutely agree. Remdesivir, don't know how much it works. It probably doesn't make much of a difference, especially once your illness is serious enough. Plasma, no data that it helps. Tocilizumab, it's a small window of opportunity. It may help. It may, watch my word, it does not mean that it will help. And usually, invariably, all these drugs, all the therapeutic modalities are used at the wrong time and way too late for them to make any difference. So in the process, we just make a shortage of the drugs, and people are thinking that this works and that works. But invariably, let me tell you, the most important things for COVID management: oxygen and steroids. These are the two most important ones. Everything else is immaterial. If I have good amount of oxygen and if I have steroids, that is the most important thing. If I don't have any other drugs, I'm fine with it as long as I have these two.
Excellent. That should be the message that should carry across all these intellectuals who are participating in this meeting. Please remember that these antiviral drugs are not life-saving drugs. So don't run after them and don't pay enormous money to this to buy these medicines. Now, when you see now we should come to a situation. Further clarity on this is Suneetha. We categorize these patients into mild, moderate, and severe. So what is the right time this patient should think of coming to the hospital, and how to get this online advice and keep at home when they have what kind of symptoms? So that is very, very important. That actually helps a lot of people who really get panicked once they get positive.
So one thing to remember is that even today, even when you're reading that a lot of people are finding it difficult to get a hospital bed and all of that, it is majority of the people with COVID still have a mild disease. Once we remove the panic button, switch off the panic button, and we start to think rationally, that's when we will try to rationalize and see what is right and what is wrong. If you're panicking, then whatever is told to you will not make sense. What are the risk factors? Increased age is a risk factor. If you have comorbidities, it's a risk factor. So that's one thing to remember. And generally, most people have a mild illness, which means fever, cough, sore throat, some headache, some aches and pains, a little bit of a vomiting or a diarrhea, loss of taste. Mind you, loss of taste is pathognomonic of COVID. That means if you have loss of smell, it means you have COVID. Does not mean that you have a severe disease. Okay. These are features suggestive of a mild illness. If you have shortness of breath, if you have drop in oxygen saturations, that is a problem.
So what is that threshold level that you should come to the hospital? What is the oxygen level that you should look for?
So what you need to do at home, when you're quarantining yourself, basically take symptomatic treatment. And symptomatic treatment means paracetamol for fever, pains and aches, and cough syrups or any of your homemade remedies. And monitor yourself. Get a pulse oximeter and check your oxygen saturations and heart rate. If your oxygen saturation is dropping from your baseline, then it's a problem. Typically, check your oxygen saturations while you're sitting at rest, and then walk for about 5, 10, 15 minutes and check your oxygen saturations. Is there a drop in oxygen saturation? If there is a drop in oxygen saturation, say you started with 98 or 99 and you're dropping to 95 or 96, that's a cause for concern. Then you have to get to the hospital or seek your doctor's opinion. You don't have to wait for it to drop to 93 or 92 or 91. You can, if you're seeing the drop with activity, that's an early sign that there is an issue. Or if you're having extreme weakness, you're just not able to get out of the chair or bed, that's a cause for concern. Then you need to get to the doctor.
So this is very important, Suneetha. There is a very thin line between how safe they are at home and when they need to come to the hospital. Most of the times patients are sent back and told them, with an advice of paracetamol and just be at home and quarantine. And sometimes you again tell the patients you are too late to come to the hospital. So there is a problem in these situations. Most of the patients, they come very late to the hospital when the oxygen drops down below 90.
Yeah. Also, if your symptoms are lasting for a longer period of time, more than 5 to 7 days, then get attention to talk to your doctor about it.
Right. So once the patient needs ventilatory support, the general perception is that we are gone. Patient is gone. So what do you need to say something on it? So the minute the patient goes on ventilator, so what are the chances that the patient would come out?
That is a difficult question to answer in a forum like this. Yes, there are a lot of actually things that we look at, not just the fact that you're on the ventilator or you're on a BiPAP or you're on an IV. The more severe the disease, the probability of having a bad outcome is high. That is for any disease, not just for COVID, for any disease. However, there are people, particularly, this is what we observed, at least even in the first wave last year. Elderly people who go on the ventilator were more difficult to get out of the ventilator and survive versus younger people who were going on the ventilator. We were able to salvage more of these people. Again, this time it's just still very early in the pandemic second wave to get a definitive make a definitive statement on this. More and more people are falling sick, but each person is different. Ventilator does not mean it is a death sentence. There are people who will survive even after going to ventilator. But yes, of course, if the fact that you have a severe disease, you have to just wait and see how things turn around with the treatment.
Exactly.
Treatment is primarily supportive.
So if it is required, we should, if the doctor suggests to go to put the patient on ventilator, we should not get panicked. We should allow the doctors to put the patient on ventilator. It is a support system. Until the patient recovers on his own, the ventilator would be out. So as you rightly said, it is definitely not a gone case. There are several parameters to look at it, and most of the patients would come out of the ventilator, even after ventilator support. Now, what is the final advice that you would like to give to the time members, Suneetha? We are done with our time. It's 8:50. We would like to hand over the session to the charter members. So what is the final? Yeah, please.
The one thing is you need to learn, you need to be aware of what is happening around in the world. Protect yourself, vaccine and mask. These are the two most important things. May 1st, I believe the country is going to roll out vaccines for pretty much everybody. So please ensure that you and your family members, everybody get vaccines. And even if you get vaccine, please use the mask. These are the two important things. And keep healthy and stay calm. Most decisions taken when you are not in a calm situation will be wrong decisions, and you can't make the right decisions. So try and stay calm. Do whatever it takes to train yourself to stay calm. If it means regular meditation or going to the temple, whatever it takes, practice that on a regular basis so that you will be able to keep control of your mind.
So don't press the panic button. So face it, deal with it. Now there's so many questions in the chat box. Suresh Garu, you want me to go ahead with that for some questions, or you're done with?
Dr. Vijay Anand, if you permit me, I just want to interrupt for 3-4 minutes.
Yeah.
We have got Barani Arol, the president of HISIA, the Hyderabad Software Enterprise Association. He wants to speak to our audience for a few minutes. Barani, all yours. Please go ahead.
Thank you very much, Suresh. A pleasure just hearing both these distinguished doctors deliberating on a very, very important issue. Very good evening, ladies and gentlemen. This is Barani Arol, the president of Hyderabad Software Enterprises Association. The acronym of that is HISIA. So as you may be aware that HISIA is the industry body for the IT industry in Hyderabad. Many thanks to Manoha and Suresh for accommodating me to share a few words on a very important campaign that HISIA has embarked on recently. The pandemic is back in a very big way, as we all know, and we need to step up our fight against this unprecedented crisis. In our interactions with local hospitals and NGOs, we have learned that there's a huge and desperate need of equipment, medicines, and trained people to step up the fight. We at HISIA have quickly identified a few local gaps where a quick intervention by the IT industry, or any corporate for that matter, or individual, will provide huge support to those engaged in this fight. More importantly, save lives. We are requesting companies and individuals to come forward and support. So let me just share with you my own example. I went to the Kondapur Primary Health Center. The situation there is absolutely horrendous. We can't even just think about getting the basic kind of service, but the situation out there is absolutely very, very disheartening to see. So that is one of the reasons why we thought the intervention should be happening at like the government public health centers, at least there, because corporates are okay, corporate hospitals are okay to some extent. But wherever we go, there's a huge demand for ICU beds and oxygen beds. So I think what we thought was our primary focus will be to support, at least to start with, Kondapur District Primary Health Center, TIMS, which is a 100% COVID hospital at Gachibowli, and later extending to the Nature Cure and Sarojini hospitals, because we want to just make at least some impact because the time is of essence. We have to immediately intervene and do something. So primarily, we just are focusing on sourcing and deploying resources such as nurses, technicians, caretakers, sanitary workers, and even oxygen technicians as well. And secondly, procure critical medical devices and drugs. And those are the very important need that we see on the ground, which needs, which are needed by the hospitals to save lives, right? And even the oxygen cylinders. So many corporations have come forward and have been contributing in whatever way they can. We are mobilizing these contributions through our NGO partner called Nirman, so that they get ATG certification. We have established a very strict governance mechanism for better transparency and effective utilization of these funds. I'm chairing this program myself, and we have been constantly reviewing the requirements and fulfillment process. So I appeal to all of you to contribute to this cause, and every day matters. Believe me, every hour matters. We'll have, I'll just share this email out to TAI and requesting the TAI management to be able to share this campaign details through an email to your member companies and the audience here. And I request everybody's support to be able to manage this crisis effectively. And at this point in time, just every bit of help would really matter. Thank you very much for that opportunity.
Bharani, thank you very much. Do you have a link that you can post in the chat group here?
Oh, yes, absolutely. Absolutely. I can do that and also send this email out, right away. Okay,
sure.
So
thank you.
Second, yes, I will do that right away.
Yeah, just post in the chat group here on the Zoom. Thank you.
Sure, I will do that. Thank you.
Thank you. Dr. Garu, back to you. I think we can take a few questions.
Sure,
it's an important topic. So either we can go through some of the questions on the chat, or if anybody has questions, you can raise your hand and we'll see if we can accommodate some of you.
Let me finish off some of the questions in the chat box, Mr. Ray.
Yeah.
Can the infection be contained through nebulization? Suneetha.
See, the virus is actually sitting inside the cell. It's not just lying on top of the on the surface of the mucosa. So, and it's there not just in the nasal mucosa, it's probably also deeper in the lung tissue. So will it be contained by the nebulization? No. Will nebulization help you with symptom management? Yes. So you can take nebulization by all means, but that's not the only, that's not necessarily going to completely remove the disease, but it will help you.
Right. Hari Bharadwaj, I think your question is already answered in the discussion about is it airborne or through the contact. Now, Miss Silpa, Doc, can dry cough be the first and the only symptom without fever?
Yes, absolutely. It can be the only symptom.
Right. Nikhil Shah, we read about C-reactive protein or D-dimer test. What is your view about its significance, if any?
See, one of the things we look for is the disease going to get severe? Generally, if you have a mild symptoms, you don't have to do any blood tests other than maybe even a basic CBP or a chest X-ray. But if your symptoms are going to persist beyond 5 days or so, then we want to look to see if you're developing the immune phenomenon, which is a cytokine storm that we're worried about. That will be a severe process. So when you have that kind of a process, we know that there are certain things that we see, biochemical changes that happen in the body. For example, if you see us do a CBP, your lymphocyte count is extremely low and the neutrophils are high. Or if you do certain other tests like CRP or D-dimer, ferritin, some of these are called inflammatory
markers.
This suggests that there is a lot more inflammation going on in the body. So if you have elevated inflammatory markers, then that's a sign that's one of the things that the doctors look for to see if you're likely to develop a severe disease and intervene before the severity occurs. So typically these tests should not be done on day one because they will be normal on day one. We'll just be wasting money doing blood tests or CT chest day one. if you're doing the CT test, not only do you waste money, but you'll also be exposing yourself to unnecessary radiation. And when you do need to do a CT, if you do need to do a CT test, say about 5 to 7 days later, then it just messes up because you don't want to give too much of radiation to the same person. So do not do blood tests and CT test on day one. Wait for a couple of days. If symptoms are not responding, that's when your doctor will tell you you need to do blood tests or CT test.
So Mr. Venkat has a very interesting question. How do we differentiate with normal fever due to viral infection with the COVID infection? It's very difficult.
There is absolutely no way to differentiate. But having said that, most of the people who are having viral symptoms today are almost always COVID in the community at the moment.
And we should get tested.
Absolutely.
Mr. Bala, can mere sore throat mean COVID? Yeah, it could be.
Yes.
Now, Shivakumar from Rachakonda, 5 weeks after first dose of Covishield, we get COVID Covaxin and have gone through the treatment and got cured and got RT-PCR test negative. Now, when should I take the second dose of Covishield after the RT-PCR negative report?
So, if you have, the question is, if I've taken the first dose of the vaccine, I've developed COVID after that. Now, when do I take the next dose? So, take the next dose after 1 month from the time of disease. Don't take it before that. Even if you're supposed to, you're 6 weeks or 7 weeks or whenever it is due, please don't take the vaccine. Wait for a month after the disease.
Right, Mr. Hita Chandra, I think we have already answered this question. If an asymptomatic COVID patient takes a COVID vaccine, so what would it, how would be the impact?
It will be like any other COVID disease.
Yeah. So, Mr. Venkat, if Covishield was given as a first dose, we get Covaxin administered as a second dose. That we have already answered.
No.
So definitely not. How do you see situation over next couple of months by Raghu, which I think Suneetha has clearly answered. So somewhere in the middle of the May or by end of May would the peak starts receding. Is that right, Suneetha?
More or less, that's the anticipation we are having.
Anticipation. Yeah, we can only anticipate. Right. Mr. Sailesh, most of the patients have been administered remdesivir, have been recovered well. Saturation levels have gone up and patients have become active. So I don't know. This is just a coincidental thing. You can answer that, Suneetha.
Let me take that question.
Yeah.
So, in the about a year ago, when we had initially we didn't have enough remdesivir stocks. After that, we were having a lot of remdesivir. So almost everybody who had COVID were asking for remdesivir, and we were being a little bit liberal for some time with administering remdesivir for people who wanted it. At that time, the thinking was, if you're having a viral infection and I give antivirals early in the course, then I probably can prevent developing the cytokine storm, which typically happens in the second week. We found all kinds of responses. Some people who got remdesivir continue to have cytokine storm in the second week. Some people who didn't have remdesivir got cytokine storm. Some people who got remdesivir did well. Some people who did not get remdesivir also did well. In fact, at one point, we were actually wondering if remdesivir was contributing to the cytokine storm in some people. Because unless there's a proper study done in a methodology with proper methodology, you can't get a definitive answer. But the general feeling that we got at the end of a couple of months of this trial and error is it probably doesn't make much of a difference, taking remdesivir in terms of preventing the development of cytokine storm. However, if you do have mild hypoxia, and that's when you come to the hospital, that's a time that we can potentially try remdesivir again. Whether it's going to help or not, it is not. We don't know at this point. Again, the most important thing that we don't know definitively makes a difference is oxygen and steroids.
Thank you, Suneetha. Ms. Divya, if you have got first dose, then got COVID, do we have to take first dose again? So Suneetha has already answered it. So we need to take the second dose 4 weeks after you get away from the COVID infection. So I have been in contact with the COVID person before 5 days when we tested positive. So do I require to get the test dose and self-quarantine? Test done and self-quarantine. This has also been answered. can repeat
Typically, the infectivity starts about 24 to 48 hours before the onset of symptoms. If it's 5 days, you're not counted.
Miss Anita, she has a question. One of the hidden epidemic with COVID is the mental health concerns of both health workers and patients and families. There is grief and bereavement. These issues need attention. For development provides counseling and psychology. Yes, of course. So that is very, very important.
Absolutely, absolutely important.
Yeah. And Dr. VVR Raju, please elaborate on immunosuppression medication and vaccination.
Okay, so I told that certain medications you should not take vaccine. So if you have been given plasma as a mode of treatment for COVID, then you do not want to take vaccine for about 3 months. Or there are other immunosuppressive drugs that are used like tocilizumab, itolizumab, baricitinib. There is a bunch of medications that are experimental drugs. Or if they've been given very, very high dose of steroids, which is typically more than 2 milligram per kg per day, then you want to delay the vaccine because your immune response will not be good.
Ms. Divya has a question. Can one go to work after 15 to 18 days after getting symptoms? Is it important to get tested again before getting back to work?
There is absolutely no point of repeating the test at any point in time. You just have to follow the quarantine duration as told by the government of India, which is 17 days at the moment. So day number 18, you can get out. This is from the onset of symptoms. The repeat test can be positive for various people for several weeks to sometimes even months, which we have seen happen from the very beginning of this epidemic also. That's because the PCR test, like I told you, picks up the DNA or the RNA, and you can have dead RNA in the system and that will be picked up. So do not bother repeating the test, because if it is positive, you generally will ignore it. If it's negative, you'll feel good. It doesn't make a difference.
Initially, Suneetha, it was 17 days, then it came to 14 days. Now they're saying 10
now
days.
It's 17 days. So, Indian government is still saying 17 days. 10 days institutional and 7 days home. But Indian government, yes, there are a lot of different guidelines around the world, but the government of India still is still in 17 days.
So, but a patient with the minimal symptoms, do you think that they can go out after 10 days? Maybe. You don't know.
Government of India guidelines, 17 days.
Okay. So what is the rock bottom SO2 readings that would require immediate medical attention?
You don't want to go to rock bottom oxygen levels, because then it means death. Any drop in oxygen saturations is when you have to go, because that's your window of opportunity to prevent a complication. If it goes really low, it's too late and the outcomes may not be as good, which is why we are saying don't wait. Life can go on for some time even if your oxygen levels are a little low. But the reason why we're talking about a drop in saturations, if even 3 points of anything, like if you start at 99 and it's going to 96, that is still a concern. Or if it's just at 93, that is still that's the window of opportunity to act to prevent a complication.
Right. So Mr. Bala has missed the answer. Just sore throat can be COVID. Yes, it can be. Yes, Suneetha, you want to answer that? So just sore throat can be COVID.
Can be COVID.
Mr. VVR Raju, a MDS patient after successful BMT, CMC says to vaccinate after 90 days of BMT, but still on medications and immunosuppressive drugs. Can we go for this vaccination after 90 days after BMT?
Absolutely. The reason why they say 90 days for BMT is, or any other transplant for that matter, not just BMT, but any other transplant, your immune suppression is most in the first couple of weeks. After that, it's gradually tapered. And by 90 days, most people will have a little lower immunosuppression. This is not a fixed rule. There are people who have complications and their immunosuppression is prolonged for longer duration. But in general, majority of the people's immunosuppression will come to some sort of a baseline by 90 days. And that's the reason why they say after 90 days, you can start your vaccinations.
Excellent. Thank you very, very much, Suneetha and Suresh and the entire TIE team, Mano Reddy Garu and others. Thanks for giving this wonderful opportunity. It has been a great pleasure participating in this meeting. I hope it would be useful, especially in this point of time. I'm sure several people have millions of questions coming. I mean, while playing golf, wherever you go, wherever you meet people, they keep asking these kind of questions. I'm so grateful to Suneetha for answering all those questions. Thanks a lot, and handing over the session to Mr. Suresh Raju garu.
Thank you, Dr.
Thank you.
Suneetha. Wonderful session. Very, very informative. Thank you, Vijay Anand Garu. Wonderful session. Covered all the questions very diligently. Thank you very much. And we'll post the video link of this by tomorrow so that everybody can play it back and listen again if needed. Thank you very, very much. Good night. Yeah.
Thank you, Dr. Vijay Anand Reddy, Mr. Suresh, and the TIE team for having me here. It's been an absolute pleasure.
Great.
Thank you.
Bye-bye.
Thank you.
Take care.
Take care. Good night.